We have a lot of material in a short amount of time, so if I start humming the Smokey the Bandit theme, you'll know why. Oops. Okay, so nothing to disclose. Learning objectives, basically, the way I set this up was to, since there's such a, I won't say a dearth of literature, but a lack of quality literature in the area of toxicology, is really trying to set up what we consider to be best practice. And so I really focused a lot on guideline-based and went from there. But keep in mind, and those of you who do a lot of toxicology know that there's a lot of variability in practice. One of my favorite quotes comes from a toxicologist I worked with early in my career, who every time I questioned what he was doing, he would say, "Steve, I'm an ER doc. We're doers, not thinkers." So we'll try to focus in on what we do and what's best practice. So in the interest of time, I'm going to skip through some of the early parts, the general management and decontamination. I think as intensivists and critical care pharmacists, we see a lot more of the antidote role, and so we'll spend a little bit more time focusing in on those individual toxins. Keeping in mind, though, just one point I wanted to make in general management is good stabilization is always critical. Sometimes we get so excited about decontamination, giving antidotes that we forget about airway breathing and circulation. And so you always want to make sure that the patients are stable, monitoring vital signs, and then start thinking about our typical realms of therapy that we focused a lot, especially yesterday, with good IV fluids, oxygen, airway management, and tests to make sure that what we think is happening is actually happening. Another important role of the pharmacist in acute toxicology is trying to determine what may have happened as everyone else, kind of like what I think of in ACLS as everyone else is trying to get everything else established and we're rolling through the crash cart. It's time that we can think through what may have happened to the patient as we can start asking these questions. What's the potential timing of the overdose, the route? What are some of the potential agents, the possible intent, which might intensify what they took and how they took it, and how soon it may have been, any history you can get from pre-hospital providers or any family or friends or coworkers that may have come along, and then looking at the onset and the progression of the patient's symptoms. There's this section in the workbook on toxidromes. We love teaching pharmacy students about toxidromes, and we love asking pharmacy school questions about toxidromes. But as you're aware, they're not real accurate when we deal with patients with acute overdoses. These symptoms sometimes aren't present at all. Sometimes they overlap, and so even though it's fun to look at them, we do try to kind of stay away and really stick with what we see as good medicine. Okay, so we'll dive into patient case number 1, which is a 53-year-old man who arrives in the ED confused and disoriented. He's unable to provide any information about his condition or medical history. You can see he's relatively unstable with a blood pressure of 85/50, elevated heart rate and respiratory rate. He's got an unmarked pill bottle in his pocket, and 2 tablets remain, and a possible drug overdose is suspected. So what would be the most appropriate thing to start with this patient? So as I mentioned, really good stabilization. There's really, we want to do some of these other things. I put a lot of information in the workbook about my, well, sort of bias, but really the thought process about avoiding the quote-unquote coma cocktail, that we're really better off trying to figure out symptomatology before we throw things like thiamine and dextrose at patients. But sending a quantitative urine drug screen would be incredibly important, but we really want to stabilize this patient first. So with that low blood pressure, elevated heart rate, trying to get fluids in them, potentially pressors if needed. As I mentioned, I'm going to skip through a lot of the general decontamination. There's a lot of information in your workbook, but as you guys are well aware, this has usually already happened or maybe not happened at all by the time they come to us in the ICU. Many of them are not routinely recommended, and I did put information as we go through each of the pertinent toxins to talk about that. I always want to mention, just to remind everyone, serum ipecac no longer available in the U.S., but we're still finding people coming into the emergency room with a bottle. So it is, I guess, fortunately, unfortunately, it's still active. There's studies out there 7 years past the expiration date that it's still effective. So we do kind of discourage people from using it, but hopefully it's going away. Gastric lavage doesn't really work all that well. There's all kinds of issues with potential water intoxication, and so we usually don't recommend it. Remember, you're putting in a relatively small bore catheter with very small holes in it, and so you can't really pull out pill fragments very well, and so it's usually a lot more effort than it's worth. Cathartics, kind of the same. They have specific indications, and we'll talk about those, but overall not really that effective. Again, activated charcoal can be very effective if done quickly, usually within the first 60 minutes, but it's incredibly rare that we get patients this quickly. There is some benefit. I think in the workbook we talk about patients or certain medications that undergo intrahepatic recirculation, and so there is some benefit in those to do the multi-dose, but otherwise, again, there's all kinds of problems you can get with activated charcoal. This is a question, sort of an area that they love to ask test questions on. My understanding is that nothing was asked on this on the first go around, but the agents that charcoal does not bind to, and so keeping in mind that if you haven't overdosed with one of these types of agents, especially the alcohols, that it wouldn't be a good idea to give charcoal because it really would be ineffective. And so there is a good amount of data with moving away from the decontamination strategies and going with the enhanced elimination strategies. And the two most common are going to be whole bowel irrigation, which is good for sustained release formulations. I've never seen one in clinical practice, but there's good data or decent data for stuffers and packers, people who are trying to hide illicit drugs, that you can help move those through the system. You have to be careful with those because they could rip as they go through, and then you've got another type of acute overdose. And so, but polyethylene glycol is the most common agent that would be used for whole bowel irrigation. And then the other one is going to be urine alkalinization, and there's some got some data as we talk about, especially the salicylates in using typically bicarbonate solutions to try to increase urine pH, to try to increase the elimination through the kidneys of these types of agents. Okay, so kind of flying through that, here's some tables. This is directly from the workbook as well on the more common doses. So if the question was asked on, well, if you were going to give charcoal, what would you give? And actually that's on the next slide, but you can see these are the most common doses of all the different types of decontamination strategies. Okay, so let's dive into the specific toxins, and I'll start with what relatively considered to be the more common one, which is acetaminophen. So there's always this question about, is it an acute toxic overdose or is it a chronic that led to an acute toxicity? And so you can see from the acute, it's usually considered to be about 10 grams as a single dose for adults and 200 milligrams per kilograms for kids. I can tell you, though, that the worst toxic acetaminophen overdose that I've ever seen in my entire career, it was a chronic overdose and not an acute. And so those become very significant because we're going to talk about trying to figure out the treatment of those. Treatment is aimed at preventing hepatotoxicity and trying to reduce overall mortality. You can see if you get to them within an hour, there is some benefit to activated charcoal, but again, it's extremely rare that patients will present that quickly. So that leads us to the more common antidote, which is acetylcysteine, which Dr. Bauer touched on briefly. There was a lot of reliance, I won't say the old days, but there's still a lot of reliance on the Rumack-Matthews nomogram, but there are a lot of limitations to it. And so now we're kind of thinking a different process that, sure, if you can get them within 8 hours, it's great to go by the Rumack-Matthews nomogram. Anyone who has a probable or possible risk by that nomogram, it's in the workbook as well. Those would be indicated for acetylcysteine. But again, because a lot of times we can't figure out when the overdose may have occurred, then we're going by different criteria. And so patients that have an increased ALT, even sometimes 24 hours or so out, quote unquote, we may still consider giving it. If their serum acetaminophen level is greater than 20, and those patients with a history of chronic ingestions exceeding 4 grams per day. And even though there's quality counseling, as I mentioned, that one case that is the worst I've ever seen, that was a patient that had a dental extraction and also got kind of a cold at the same time. It was taking Vicodin for the dental extraction, it was taking Tylenol for a fever, and was taking another, we think it was something like a NyQuil that had acetaminophen in it as well. We calculated somewhere in the range of about 8 grams a day over about 48 hours, and unfortunately died in about 72 hours after that. So there, as I mentioned, there's a lot of limitations to the Rumack-Matthews nomogram. Knowing when they presented, probably the biggest one. Patients also and their families are very unreliable about what could have been taken. A lot of times there's hiding of medication bottles and things like that to try to avoid the ability for antidotes to be given. If there's an overdose associated with the extended release formulations, it's incredibly inaccurate. If this is a chronic or repeated supertherapeutic ingestions, and if patients were taking any medications that may interact, especially with the cytochrome P450 system, makes that nomogram very unreliable. So if it's determined that you do want to give, there are several different dosing strategies. The one that's mostly accepted in the literature is to give the quote-unquote acetadote formulation, or the IV formulation, which is the 150 milligrams per kilogram over 60 minutes, followed by the 50 per kilo over 4 hours, then the 100 per kilo over 16 hours. There is still some usage of the oral. My docs seem to think it's funny to give the oral acetylcysteine as a quote-unquote punishment to the patients for thinking twice about doing it again. But if the patient's stable and they want to give it and you don't want to necessarily put an IV line, then there is some indication for that. Is anyone using the oral capsules for N-acetylcysteine dosing? Okay, I've not seen it used for acetaminophen overdose, a little bit for the, the contrast agents, but have not seen it for that indication. And then if you don't have we had a shortage of acetadote for a while, and I know that a lot of the regional poison control centers were going back to the old days when we were taking the inhalational and converting it over to IV with filtration. And so that's still a possibility. There's some debate about using 12 doses instead of 17 if you do that formulation, but we try to avoid that one because of the anaphylactic reactions. That is still out there. And then a lot of the poison control centers, a lot of the clinical toxicologists are recommending shorter durations and not continuing out the full doses if these all of these are met. So they would have to have all three. That if the serum acetaminophen levels are dropped below 10 or completely undetectable, if their liver enzymes are normal or improving and the patient's clinically improving, and this is more so with the oral dosing because that takes a lot longer than the 21 hours of the IV. But again, there is a possibility that you could do sort of a shorter course with the IV as well. Okay, so that takes us into our next case, which is a 42-year-old woman who presents to the ED with symptoms of headache, congestion, severe nausea and vomiting, abdominal pain, and some confusion. Taking acetaminophen 500 milligram caplets as needed, but ran out of the bottle that she had just purchased yesterday. You can see vital signs relatively stable. Acetaminophen levels is 100, and AST and ALT are elevated. So which general management strategy would be most indicated at this time? Good. You could certainly consider, I would agree, I think B is the correct answer. Continuous stabilization is probably the most important thing. She's relatively stable at this point, so hopefully not much more would be needed. There is a possibility to give the activated charcoal, but again, it would be most effective if within 1 hour. And this is probably more of, even though it's only been about a day, more of a chronic overdose. And so a little bit more questionable to do that. It wouldn't be wrong. A lot of times, again, we're doers, not thinkers. We would probably have given, and certainly my institution, we would give the activated charcoal. But I think 2 is the more appropriate answer. Okay, and then what's the most appropriate treatment for her acetaminophen toxicity? Okay, so a little differentiation there. Again, any of the answers are probably okay in clinical practice. I think the best answer is going to be the traditional IV formulation over the 21 hours, which is answer number C or 3. Again, if you didn't have it available, certainly consider the converting the inhalational to the IV. But with the severe nausea and vomiting, probably not a good idea to do the oral formulation at this time. Oops. Not sure how that got there. Okay, so salicylates. So moving on to our next one, salicylates, still relatively common. I don't know if you've seen many cases of salicylate overdose, but surprisingly still out there. Interestingly enough, this kind of graph or table is relatively accurate, that their symptoms pretty well define the level in the serum that they would have. And so you can see less than 30 asymptomatic, 15 to 30 is what's considered to be therapeutic. And then as we get to the more mild overdoses, a little bit of nausea, maybe some tinnitus or dizziness. But as you get into the more severe, you can see the coma, seizures, hallucinations, stupor, cerebral edema, and such. And this is where it gets really difficult to treat these types of patients. Problem with salicylates, there's no specific antidote, nothing like acetylcysteine. Again, within an hour, you can consider giving single-dose activated charcoal. If the levels are going up, there is some data to indicate that multi-dose would be effective, and we have done that strategy. But other than that, it's really just stabilization of the patient. So IV fluids, if they're hypotensive or any signs and symptoms of dehydration, IV dextrose, especially if they're hypoglycemic. The one strategy that probably is going to be most effective is the urine alkalinization. And so, again, as we talked about earlier on that slide, giving the sodium bicarb infusion to try to get their urine pH above 7.5. Because you're doing that, you may need to replace their potassium, so we don't recommend it as a kind of a prophylactic strategy, but just to monitor levels and administer if needed. And then in real severe cases, especially those with as we talked about, levels above 70, you can consider hemodialysis. Okay, so that takes us into another case, which is a 62-year-old man that presents to the ED alert and oriented, nausea, tachypnea, worsening flu-like symptoms. He's got past medical history of stroke and hypertension. Vital signs are relatively stable. He's got an ABG that's pH is 7.5, PCO2 25, and a bicarb of 20, and his salicylate level is 25. So which treatment management strategy is most indicated for this patient? This one I threw in there just to see what people would say. There's a strong debate between 1 and 3, and certainly there's no need for endotracheal intubation at this time, but certainly needing to be ready just in case. And then hemodialysis if it was more severe and the levels were elevated. What we would probably do for this patient would be start the bicarb infusion, and that's what I intended the answer to be. But the patient is so stable and their level is not actually elevated, and so there's a good question that you potentially don't have to do anything and use the sodium chloride infusion. And so when I wrote the answer in the workbook, it was to lead you towards the potential answer of sodium bicarb. But I wanted to kind of throw just one curveball in there. I wasn't trying to be mean. I just wanted to kind of see what everyone would say. Okay, I don't know why that's underlining. Let's just ignore that part. Okay, so let's move into the opioids. And opioids are getting interesting, more so in the acute stage. There's all this talk about the intranasal naloxone, which I think is all really cool, but we tend to not do that so much in the ICU. Clinical symptoms, respiratory depression is going to be the big one, which is pretty well defined as less than 12 breaths per minute. You can also, hopefully we don't get to coma, but meiosis, which is very nondescript. Hypoactive bowel sounds, again, very nondescript. Diagnosis, you can do a 12-lead, ABG, and then electrolytes, glucose, and checking a CK level. But treatment really is going to be good stabilization. And so put in their airway stabilization, supplemental oxygen if needed. If their blood pressure is low, usually defined by systolic less than 90, then crystalloid IV fluids are usually a good starting point. Again, within an hour, single-dose activated charcoal. Some institutions are doing whole bowel irrigations, especially if it's a more of an extended release product. And then naloxone, again, it's a little bit controversial as far as the dosing is concerned. And I threw out what's considered to be, I guess, quote unquote, best practice, which you would start at a dose of 0.5, and then you double that dose every 2 to 3 minutes. So you go to 2, then to 4, and then up to 10, and as much as 15. I know some people are averse to using doses that high, but it can be very effective. But what I would really encourage you to consider would be the continuous infusion. There's pretty decent data out there that's more effective than these repeated boluses. And so the range can be anywhere from 0.04 to 4. We typically start at 0.1 and titrate up from there. We usually don't have to do much more titration. Usually the patients are, we've kind of gone overboard at this point. My institution, these patients are typically intubated the second that this goes, because it's usually called as a code blue. And so they'll intubate them, bring in the ICU. And then we kind of run through that whole idea of, do we just ride the storm and leave them intubated, or do you give them a reversal agent? And we typically do like to give the idea of the reversal agent because we don't want the thought process to reduce the time period that they'll be mechanically ventilated and reduce all the side adverse events that can happen with that. It seems like there was one more thing I was going to mention with the opioids. Oh, the only other thing I was going to mention is that there is some data out there. We do this in clinical practice. I don't know how effective it really is, but we'll check a qualitative urine screen to kind of give us an idea of how well they're coming off of it. We just check for presence of opioids just to see if but I don't advocate that necessarily for an endpoint of naloxone therapy. Usually once you're starting to see a good reversal, they're weaning down their vent settings and ready for extubation, that's usually the time that we stop the infusion, but there is a few case reports and case series out there about potentially using that just the qualitative. It doesn't matter what number you're getting, just the presence, and letting that guide your naloxone infusion. Okay, moving into the alcohols, most commonly, we're going to talk about methanol and ethylene glycol. The symptoms, very similar to ethanol. Inebriation, altered mental status. The patients can have pretty severe or potentially intractable nausea and vomiting, nystagmus, and depressed reflexes. Typically, what we measure on these patients is going to be an osmolar gap, and then we can, if your lab can do it, you can check serum methanol, ethylene glycol levels. There is some benefit to gastric lavage if you can get it quickly within an hour. Again, it's pretty rare that these patients will present that quickly. I put ethanol treatment as controversial. I don't want to get into the ethics of that. I worked with some trauma docs back in my early career that said that we were not a rehab center, and so their thought process was just give them ethanol and let them ride the storm. I don't advocate that. It's not easy to do. Show of hands if you're using ethanol therapy. A few people. Anyone still doing IV? Okay, a couple people. Excellent. Yeah, I mean, we did it all the time. It's hard to now because it's not commercially available to get those D5A5 or D5A10 drips. So you have to kind of compound your own. But it's incredibly effective. We just kind of moved out of that realm. And so really the drug of choice for these patients is considered to be fomepizole. You can also consider the cofactors. I think in the algorithm that created, it talks about giving the cofactors. These patients are usually hypoglycemic, and so administration of dextrose is a good idea, along with magnesium, as they're typically nutritionally deplete as well. There may be a need for anti-seizure medications, and then also the potential in real severe cases of hemodialysis. This has been a lot in the lay press about hemodialysis, especially with some of these binge drinking acute things, like the fraternity sorority hazing episodes. That's been a lot in the lay press, and so it's actually carried over to, we get a lot of questions when patients come in, or is so-and-so going to be dialyzed, and we're starting to figure out that's where it's coming from. And so a quick algorithm is that if their glucose is less than 70, we typically give them like the quote-unquote 1 amp of D50. If their pH is less than 7.3, we'll do, again, the quote-unquote 1 amp of bicarb, the 50 mLs. If they're seizing, we had that discussion this morning, so I won't reiterate, but benzodiazepines are usually the drug of choice. The cofactors, thiamine 100 milligrams and pyridoxine 50 milligrams, IV every 4 to 6 hours. And you can consider, really the guidelines still talk about folinic acid, but we know it's not so easy to get a hold of, so folic acid usually is just fine for that indication. Then you can go through the indications for the antidotes, which is the methanol levels, ethylene glycol above 20, or history of ingestion and methanol above, or an osmolar gap above 10, history or strong clinical suspicion of poisoning in any of the following criteria, pH less than 7.3, and the presence of urinary oxalate crystals. So if you don't have those, we usually go through the process of trying to figure out what else might be going on. If we have those, then we go straight to fomepizole. And that's 15 milligrams per kilograms as a bolus, then 10 per kilo every 12 hours for 4 doses, then 15 per kilo every 12 hours. They love asking questions about hemodialysis because it is pretty significantly removed. So we go to doses every 4 hours and then go back to every 12 once they come off dialysis. So if it's just one period, we'll do every 4 hours while they're getting dialysis and then switch them back to Q12 right after. And then I put in the dosing for ethanol if that's still a consideration. Again, a lot of institutions have moved away from that, but essentially what you're doing is you're trying to get them to a basically drunk. You're trying to get them to a blood alcohol level of 100 or 0.1. And then here's some indications for hemodialysis. Again, it's only really in severe cases, but something to consider. So here we have a 35-year-old man who's admitted to the emergency department. He appears inebriated. He's alert but oriented only to person. Blood pressure 122/80, heart rate of 82, respiratory rate of 25. Serum ethanol concentration is 20, and ethylene glycol concentration of 100. And this is pretty common to see those together. So what would be the most appropriate therapy at this time? Good. Most of you went with fomepizole. So again, if your institution can do ethanol, certainly that's a possibility. Fomepizole does seem to be a little bit better of an agent, much easier to administer. The cofactors would be important, but probably better to get the antidote started first. And then again, not knowing exactly when this patient came in. Well, actually, activated charcoal wouldn't be appropriate because it doesn't bind to the alcohols. So then the patient is on hemodialysis with methanol intoxication initiated on fameprazole treatment. So basically this is asking, would you adjust the dose, and if so, how? Good, everyone, for the most part, went with answer 3, which is to increase the interval to every 4 hours. Okay, so moving into the cardiovascular medications, and still these are still relatively common, really talking about the beta blockers for the most part and the calcium channel blockers. And what we're typically worried about is going to be, just as you would expect, hypotension, bradycardia. So there is some indication for gastric lavage, activated charcoal. There is some data to extend it out to 2 hours after the ingestion. So if you can get them quick enough, there is some potential for that. There's a lot of debate about using whole bowel irrigation for the sustained release formulations like the metoprolol XL or all the different types of diltiazem formulations and verapamil. Again, it's a bit controversial because there's been some data coming out saying there may not be much benefit, but for the most part, we will do that to try to encourage those to get through the full GI tract, because there is good data with absorption in the later parts of the GI tract. So the goals are to keep their MAP above 65, their systolic above 90. Good idea to start with isotonic fluids like lactate ringers or 0.9% sodium chloride. Certainly can consider colloids here as well, but if the patient was fluid overloaded or congestive heart failure, but typically the isotonic fluids are preferred. And then, especially for the calcium channel blockers, a little bit more controversial for the beta blockers, is to give calcium. And so calcium chloride 1 to 2 grams or calcium gluconate 3 to 6 grams. I want to remind everyone, or maybe just tell everyone that even though we don't prefer it and it can cause a lot of problems, if emergency situation arises and we only have peripheral, we can give chloride peripherally. Don't like to do that. We follow it with lots of flushes because it is extremely irritating, but that is a possibility. And then remembering that gluconate is only 1/3 of the calcium salt, elemental salt concentration, and so usually 3 times the amount that you would give as chloride. This, I debate about just taking it out completely, although my institution still loves glucagon, that there's a lot better agents to use and a lot better strategies to do for bradycardia and hypotension. Most people have completely gone away, especially with the new ACLS guidelines about giving atropine, but there is a potential benefit if there's symptomatic bradycardia. Again, glucagon has its place in therapy. I'm not sure how great it is, but my docs love glucagon. And then the vasopressors, there is some data to say that norepinephrine and dopamine may be the preferred in these types of scenarios. Again, it's really whichever one you can get in the most quickly, but we usually try to focus towards norepinephrine and dopamine as our drugs of choice. What's probably preferred is the HIET or HIDK, lots of different synonyms for this type of therapy, but giving the insulin to try to very similar to how we do DKA dosing, and so the initial 1 unit per kilo bolus, and then 0.5 to 1 units per kilo per hour. Actually, that should be 0.1. I made a mistake there. Because, again, you're going to be giving them a lot of insulin, is that you're going to be pushing the dextrose into the cell. And so if their glucose is less than 200, then you're probably going to have to give glucose therapy. We usually just go ahead and give it simultaneously. And then since you're pushing calcium or potassium intracellularly as well, is to replace their potassium if it drops below 2.8 to 3. Another potential source of therapy is the intravenous lipids. There's a lot of controversy as far as what the dosing should be. This is what's most commonly quoted in the literature. We don't actually do intravenous lipids, but I've talked to a lot of colleagues that do, and this is the more common dose. And so 1.5 mLs per kilo bolus, are typically about 100 mLs of the 20% fat emulsion. And then you do an infusion of 0.25 to 0.1 mLs per kilo per minute for 60 minutes. And typically it's stopped after that. There's no continuation after 1 hour. And so again, just trying to think through the process, created another algorithm for this. So if they show up, are they within an hour, then consider giving activated charcoal, gastric lavage, whole bowel irrigation. If their blood pressure is low, then really this is the sequence that we go through. And so start with IV fluids, typically the crystalloids at 20 to 30 mLs per kilo. Go ahead and give them the calcium, then start insulin. If that doesn't work, then we go to vasopressors, and if that doesn't work, maybe consider IV lipid emulsion. And you could potentially move that up, maybe even after insulin. But again, with my relative inexperience with it, again, talking to colleagues that have done it, they actually do it after this step. So they would do the insulin first, then the IV lipid emulsion before they go to vasopressors. And then interestingly, there's some data coming out about the use of extracorporeal life support. And so there is that thought process as well. And if they're symptomatic, then's the time to think about maybe atropine, maybe glucagon, or maybe even a temporary pacemaker, and then following those patients until you get hemodynamic improvement. So that leads us into a case regarding this. It's a 52-year-old male admitted to the emergency department with dizziness and headache, vital signs, temperature 98.9, blood pressure 87/50, heart rate of 58. Past medical history, hypertension, early stages of Alzheimer's disease, medication bottles. 1 month supply was refilled 2 days ago. The DILT 120, there's only seven tablets left, but the donepezil 5, there's 28 tablets remaining. So what decontamination strategy would provide the most benefit for this patient? And probably the best answer at this point in time would be, because he took the diltiazem XL, would be to go ahead and give him the whole bowel irrigation. And then which antidote would you administer first? Excellent. So even though the dose is a little bit on the wimpy side, just given a gram of calcium chloride, that would probably be the best answer at this point in time. Okay, digoxin, I work with an older patient population that still uses a lot of digoxin, and so we do see this. Again, I kind of debated taking this out because it's not as common anymore. But symptoms, typically what you see is heart block, and that can be up to as a complete heart block. Although typically you're going to see bradyarrhythmias, sometimes you can see tachyarrhythmias. Nausea and vomiting can be pretty severe. I won't say intractable, but it is pretty bad. And then with more the higher levels for patients, lethargy, confusion, and we don't really see much of the visual disturbances anymore. That's always the fun one with the green aura, but not as common anymore. So decontamination is typically indicated for digoxin, and so multi-dose activated charcoal is the best strategy. So giving them 50 to 100 grams, and then there's a lot of debate in the literature as where to go from that point. And so I put the 3 most common strategies, which is 10 grams every hour, 10 to 20 every 2 hours, or 40 every 4 hours. And I don't have a preference on this one of which one we do. Typically, we'll do the every 2 hour one just to kind of give them a break. But again, it's a little bit controversial there. There is some data about the use of cholestyramine as a binding agent, but I put controversial because it is not any great literature either direction on how effective it might be. And probably more critical is correction of serum electrolytes. And so trying to get their potassium, magnesium, and calcium. And I give you rough ranges to get to. It's not a priority to focus on an actual number, but just to try to continue to replace it if it continues to be low. The digoxin immune antigen binding fragments, they're kind of gone full cycle with those. I think I felt like 5-10 years ago, they almost fell completely out of favor. We felt like we could control the symptoms without it. They were very expensive. They were oftentimes difficult to get a hold of. But we've kind of gone full circle and starting to use them a little bit more again, mostly because of difficulty to control the symptoms with other types of strategies. And so indications, what we think about is life-threatening arrhythmias, patients with end organ damage, or severe hyperkalemia, and I can't focus on a number with that, but usually we're talking about symptomatic hyperkalemia. And then the products, either Digibind or Digifab. And then there's a lot of different strategies on how to dose, and so I try to give you what's most commonly used. So if you have no earthly idea what they may have taken, you can't quickly get a level, then for an acute overdose, 10 to 20 vials. For a chronic overdose, roughly about 6 vials. If you know the amount that was ingested, you can plug it into this calculation and figure out how many vials to give for that point. And if you don't know how much was ingested, but you can quickly get a qualitative level, then you can calculate a dose of vials based upon their serum dig level. Okay, so then moving into some of the antidepressants, antipsychotics. How are we doing on time? Yeah, we've got a little bit longer to go. Interesting with these agents, a lot of them, times people report almost completely asymptomatic. What you can see is drowsiness, tremor, acute mental status changes, nausea and vomiting, tachycardia, hypotension, seizures, and QT interval prolongation. Probably more concerning are the tricyclics. However, these, as we all are aware, these have kind of fallen out of favor, but there are certain indications where they are preferred. And so always worried about the cardiovascular effects with them. Getting into the treatment of the antidepressants, again, there's really no specific antidotes for these. You're kind of seeing this theme over and over again, as if you can catch them quickly within an hour, then there's some indication for activated charcoal. But the key thing is good airway breathing and circulation. So crystalloids or even potentially colloids to kind of keep their blood pressure above 90 systolic and a heart rate above 60. Vasopressors if needed, and norepinephrine and epinephrine have the best data with these agents. Trying to correct their serum electrolytes, and then seizure control with the benzodiazepines as a preferred agent. And then typically our second line is going to be phenobarbital. With the tricyclics, very similar to the salicylates, the preferred treatment is going to be urine alkalization to a pH of 7.45 to 7.55. Typically what we do is we give them sodium bicarb, 1 milliequivalent per kilogram, and you could repeat that every 15 minutes. You can consider a continuous infusion, but again, if you don't want IV access or can't get IV access, and you don't want to tie up a line, because that might be the only line that you have. Typically, these patients may have one peripheral. And so a thought process is probably okay just to give them the repeat IV injections. And so the indications for that would be a prolonged QRS, wide complex tachycardia, patients in cardiac arrest, right bundle branch block, or refractory hypotension. Oops. So patient case number 7, 21-year-old man is admitted to the ED, took 30 citalopram 20 milligram tablets about 2 hours ago. You can see the vitals, 125/85, heart rate of 77, respiratory rate of 15, and a temperature of 98.7. So what would be the best intervention for this patient at this time? Would you administer lorazepam 2 milligrams to prevent seizures, closely monitor for the development of any toxic effects, recommend a cooling blanket to prevent serotonin syndrome-related hyperthermia, or order a 12-lead to monitor for cardiac conduction disturbances? Okay, so I kind of figured this would be the result. Probably the best answer at this point in time, because he took citalopram, would be to go ahead and check a cardiac monitor just to see how he's doing, and just for caution's sake. You could very strongly argue that just continue to monitor him, because he's really not showing any signs or symptoms of clinical instability, I suppose is the best way to describe that. And so thought process for that one, but I think at this point in time, checking the 12-lead would be indicated just to make sure nothing's going on. Okay, so that takes us into the atypical antipsychotics, and these are often asymptomatic with self-limiting effects. There's been case reports in up to, I think I've seen 10,000 milligrams of some of these agents with absolutely no effects whatsoever. And so it's always the ones that you don't expect that are going to catch you. But the common symptoms, typically CNS depression, tachycardia, hypotension, and QT interval prolongation. As with the other agents, no specific antidote, so good supportive care is going to be the key. So single-dose activated charcoal within an hour. Crystalloids, colloids, trying to keep the systolic above 90, heart rate above 60. For these types of agents, norepinephrine, you're kind of getting that general theme that this is going to be preferred for most agents, so that's typically our go-to. But because these agents do have some alpha activity, phenylephrine is a potential good option as well. Correction of their serum electrolytes, really focusing in on their potassium and their magnesium. Give them sodium bicarb for QRS prolongation, but that's really just for quetiapine. And so there's, again, I might want to star that one. I don't know if they threw any curveball trick questions on the first go around on the exam, but that really is only for that agent. And in seizure control, you're kind of seeing a general theme for these agents that benzodiazepines have the probably preferred, then considering phenobarbital, and then potentially propofol if you have the ability to do that, and they are intubated. With treatment, there is some good data for the intravenous fat emulsions, and so with the 20% intralipid. So a little bit different of a dose than we talked about for the cardiovascular agents, but the bolus of 1.5 mLs per kilo infused over 2 to 3 minutes, and then an infusion of 15 mLs per kilo over 60 minutes. Okay, so we got a 24-year-old woman who's brought to the ED in normal state of health, but the roommate says she seems really out of it. She refilled her olanzapine 5 milligrams, but the bottle's empty. Physical exam alert and oriented ×3, but she's dozing off during the exam. Vital signs are stable, and the 12 lead shows sinus tachycardia. So which intervention would be most appropriate for this patient? A bolus of lactated ringers, 50 mLs of sodium bicarb, lorazepam 2 milligrams, or clinical monitoring for 6 hours. So for this one, really, it's okay to do nothing. And then sometimes when we're in the heat of things, it's hard to kind of do that. You always want to do something. But this one, probably clinical monitoring would be the most indicated. You could argue longer than 6 hours, but I think at a minimum of 6 hours. Patient's relatively stable. You certainly could consider lactated ringers as a small bolus. But I think the most important thing, or probably the most appropriate thing at this point in time, would be just clinical monitoring. Okay, and then the last couple things to talk about, lithium. Again, I work in an older population with, unfortunately, a lot of psychotic issues, and so we do see our fair amount of lithium. And so it's often asymptomatic with relatively self-limiting side effects, but you can see some of the things that we're more worried about in acute overdose, some GI side effects, but really worried about the cardiovascular and the CNS side effects. And then for patients who have acute on chronic overdose, you can see things like hypothyroidism, myxedema coma, and nephrogenic DI. So for lithium, just like we talked about for most of the others, is just good supportive care. Again, no specific antidote. There is some of the sustained release formulations used still out there, and so considering whole bowel irrigation. Crystalloids to maintain good blood pressure. Again, the typical systolic over 90, heart rate above 60. Vasopressors if needed. There isn't real good data to say one is preferred over another, but as ICU clinicians, typically norepinephrine would be our drug of choice. Watching the serum electrolytes, and especially if there's a high urine output, because some of these patients may have a nephrogenic DI, is volume replacement with electrolyte replacement. And then again, seizure control, you're seeing this common theme of, in this realm, benzodiazepines, phenobarbital, and propofol, just because there's just not good data with some of the other agents. Not to say you couldn't use levetiracetam, or actually lacosamide is gaining a lot of favor in our institution. And so you can certainly consider those types of agents, but the data, at least for right now, is a little bit better with those three. So other things that we'll do, the 0.9% sodium chloride to maintain serum sodium levels of 140 to about 145. Doesn't have to be exact, but that's the range that we'll shoot for. And then that's because lithium clearance is decreased with hyponatremia. And so a lot of these patients will come in with relatively low serum sodium levels. And so we will do that as an encouragement to get rid of it. It's been a long time since I've done dialysis for lithium, just because we just don't see them quite that often. But the interesting thing about it is that you might need multiple sessions of hemodialysis, and so usually the preference is to go to CRRT if you're going to do it. And the typical indications are going to be severe toxicity, usually with severe acute mental status changes or patients seizing if they're in renal failure, and then that you can see the thresholds of the lithium concentrations above 4 in an acute overdose and above 2.5 in a chronic overdose. And then the last area to cover was the oral hypoglycemics. We don't typically see a lot of these, but when we do, they're typically pretty severe. So severe symptoms, seizures, palpitations, tachyarrhythmias, electrolyte abnormalities, and with metformin, the lactic acidosis. General symptoms, metformin, interestingly enough, does not cause hypoglycemia. And so with the other types of agents, you will see that: nausea and vomiting, dizziness, tachycardia, and diaphoresis. So the treatment really is just to get them some glucose. And so patient stabilization, number one, again, considering the activated charcoal within an hour. And then if they're symptomatic or if their serum glucose levels are less than 60, then we can try oral carbohydrates or oral glucose tablets. You know, if they're awake and alert enough, there's certainly nothing wrong with giving them orange juice or something of that extent. We typically like to be more interventional. And so we're going to give them IV dextrose. Usually the bolus is 0.5 to 1 gram per kilo. And then you just continue monitoring them, and you just kind of give it as needed. So repeat doses if necessary. Try to monitor them every 15 minutes with usually a finger stick is good enough. Continuous infusion of dextrose if needed. We usually don't advocate the D10, D20. We'll get requests for that a lot, but usually they do just fine with D5 solutions. Again, if they're getting a little fluid overloaded, you might consider the D10 solutions. And very important to avoid overcorrection, because again, these are typically diabetic patients, and so although we've seen a couple overdoses in people just grabbing bottles off the shelf of family members and things like that, but important to try to avoid overcorrection. And so this one doesn't show up as well. I didn't cut it down as much, but it's in the workbook. But again, if you get them within an hour, their glucose is less than 70, consider activated charcoal, administer glucose. If they're awake and alert, an oral carbohydrate, you can do the glucose tabs, or again, sodas, orange juices. We did have the mistake once where someone gave them a Diet Coke, and that, of course, didn't help. If altered mental status, then we typically go straight to the IV, although our emergency docs just go straight to IV no matter what. And then repeat doses as needed. You can see if it's greater than 70 for 2 consecutive readings, then you're pretty much done. You can just monitor them. If not, then you might consider some of the other agents like octreotide or even potentially glucagon, but those have really fallen out of favor. Still some usage, but really most of the stuff that's coming out really is discouraging the use of those agents because of the different types of adverse effects and efficacy, and really just sticking with glucose as much as possible. All right, so that takes us into our last question, which we have 1 minute for. So patient in the cardiac step-down unit found unconscious, received glyburide 20 milligrams an hour earlier, was meant for another patient. Vital signs are stable, point of care glucose is 37, and this is based on an actual case at our institution. Sorry to say that. Which intervention is most appropriate at this time? So would you do 8 ounces of milk, 50 mLs of 50% dextrose, octreotide, or glucagon? Okay, most of you put dextrose, and that would be the correct answer. If that failed to work and repeat doses, consider octreotide, glucagon. I wasn't trying to trick anyone. Milk's actually a great source of glucose, and so if they were awake and alert, you certainly could do that. But this patient being unconscious, we want to go straight to IV.